Pacific trial is a phase 2 trial that was conducted in Malaysia and South Korea, where the treatment patterns are somewhat different than they are in the US, that are more permissive than our criteria. Part of it, I think, has to do with culturally differences in people's tolerance for phlebotomy. And so the majority of patients receive less phlebotomy and are treated with hydroxyurea at relatively low doses, even when they are low risk. The Pacific trial was a phase 2 trial conducted in Malaysia and South Korea. It was an open label clinical study that enrolled 20 patients, all of whom were diagnosed with PV on the basis of the WHO criteria, and who had a hematocrit of at least 48 on 3 or more occasions in the 28 weeks prior to dosing, or 5 or more events of hematocrit being above 48% in 52 weeks or a year prior to dosing. As I mentioned, the majority of the patients were treated with hydroxyurea concurrently at 500 milligrams a day, and they were started on Rusfertide 40 milligrams twice weekly at least 3 days apart. And the primary efficacy was time to the first hematocrit below 45%, the proportion of subjects with hematocrit below 45% at week 16, and time to the first hematocrit above 45% thereafter. And they also collected data on the tapering of cytoreductive agents, but that has not yet been reported. Iron deficiency is ubiquitous in the PV population. Many of the symptoms that they experience that we believe are disease-specific are reminiscent of the side effects experienced in non-PV patients with iron deficiency. So that's the one reason, is that it's prevalent in this population and may contribute to symptoms. And the other is that it's very difficult to treat. There isn't really a therapy specifically for iron deficiency in this patient population, and that the therapy, in fact, induces iron deficiency. So many of the patients who present iron deficient before they initiate phlebotomy, it just gets worse with the repeated phlebotomies that they receive to maintain their hematocrit in goal. Like I said, in this specific study, the hematocrits of the management of patients vis-a-vis their hematocrit is more permissive, and I don't have results on this patient's population symptom burden, so I don't know how to exactly answer that more specifically about this study, but more generally, it's because of the ubiquity of finding iron deficiency in this population, as well as the possibility of the associated symptoms. So what I think it allowed us to do by looking specifically at this population is to extrapolate what might happen in newly diagnosed patients in the US or in the Western hemisphere, where the treatment guidelines suggest that hematocrit targets should be below 45%. And so being able to evaluate patients whose hematocrit is above 45% gives us a sense of the kinetics, the rate at which Rusfertide impacts the hematocrit, and the results certainly show that within a very short amount of time, within 8 weeks, hematocrits are normalized, somewhere between 4 and 8 weeks, which is which is in some cases difficult to do when patients first present with extremely elevated hematocrits, and repeat and frequent phlebotomy in that period would be required to get that hematocrit in line with our NCCN guidelines. I think that the possibility that this agent can be used in low-risk PV patients who are being de novo diagnosed is a possibility. That's a next possible step after its approval. The other is the idea of understanding how iron metabolism is dysregulated in this population. A third is a window into understanding whether a robust and sustained hematocrit control that is very difficult to accomplish in patients who require frequent repeat phlebotomy, that we would over time be able to accrue data on the thrombotic risk of exclusively controlling the hematocrit in that kind of robust and continuous way. Thrombotic rates are a relatively low frequency occurrence in this population, although it's still something that occurs more significantly than in the general population, but the frequency in well-controlled patients is still somewhere between 2 and 3%. So being able to ask that question robustly in a clinical trial is impractical, but once it is approved, we would be able to ask the question, does sustained continuous hematocrit control reduce the rate of thrombotic complications in PV patients, low-risk PV patients, or even high-risk PV patients who are already on cytoreductive agents? I think those are important next steps. And that's another way of considering the question of, is the elevated white count and elevated platelet count, are elevated white counts and elevated platelet counts important additional parameters? Because obviously if you can control hematocrit and reduce the risk of thrombosis, then the impact of the elevated white count and elevated platelet count becomes less relevant in this patient population. It is currently not thought to be as important as hematocrit control, but the jury is still out about their overall importance. I don't think it's quite as well accepted as the hematocrit is to the importance of control in this population. I think what we can see from the data on both transferrin saturation and ferritin is that treatment over the course of a year results in a new plateau. Both the transferrin saturation and the ferritin, which are both ubiquitously used markers for iron status, are both increased into the normal range, and that they plateau over the course of the year. And so it's important to see that the iron deficiency in these patients appears to be normalized. And it also shows that in the patients who are most iron deficient at baseline, at the start of the trial, you get the most benefit in terms of their hematopoiesis. The hematopoietic iron status is improved most robustly in the patients who are the most iron deficient at the beginning.